Highlights of the BREEZE study for TYVASO DPI, presented by a clinical investigator.
Hello, I am Ricardo Restrepo, Associate Professor at the University of South Florida in Tampa and Director of the Pulmonary Vascular Disease Center and Pulmonary Hypertension. Today, I will be discussing some of the important highlights from the BREEZE study for TYVASO DPI. TYVASO DPI is the first of its kind dry powder inhaler indicated for the treatment of pulmonary arterial hypertension and pulmonary hypertension associated with interstitial lung disease to improve exercisability.
What was the purpose of the BREEZE study?
The purpose of the BREEZE study was to evaluate the safety and tolerability of switching from nebulized TYVASO to TYVASO DPI. It was an open-label study. There was no placebo arm, and all the patients received the active medication. During the BREEZE study, we enrolled 51 patients with pulmonary arterial hypertension who had been on TYVASO for at least 3 months and were on a stable dose. Out of those patients, 80% were also on dual background therapy, and 61% were functional class 2. BREEZE was designed with a 3-week treatment phase during which the patients were switched from TYVASO nebulized to the corresponding dose of the TYVASO DPI. During this phase, patients were evaluated for safety and tolerability, pharmacokinetics, 6-minute walk distance, and patient-reported outcomes. After 3 weeks, 49 of the 51 patients elected to remain on the TYVASO DPI as part of the optional extension phase of the BREEZE study. They were continued to be monitored and evaluated throughout. To me, that showed that patients were happy with the device and with the results of the medication.
How would you characterize the safety and tolerability results of BREEZE?
Safety and tolerability were consistent with what we saw in the previous studies with the nebulized TYVASO. Most common adverse event was cough, seen in 35% of the patients, followed by headache. That was another adverse event seen in 16% of the patients. These adverse events are also the ones that we see more commonly in our clinical practice using nebulized TYVASO. 2 patients discontinued TYVASO DPI due to adverse event in the treatment phase, and they returned to nebulized TYVASO. The low discontinuation rate confirmed for me that the patient's acceptance and ability to adapt to the new device.
What other findings of the BREEZE study do you consider clinically relevant?
In addition to safety and tolerability, BREEZE showed several other positive results. When we analyzed the pharmacokinetics, we saw that the systemic exposure of TYVASO DPI was very similar to that of TYVASO nebulized. One of the most important criteria was the 6-minute walk distance. Besides the usual gain that patients with pulmonary arterial hypertension get using TYVASO nebulized, when they switched to TYVASO DPI, they had an additional gain of 11.5 meters at week 3 from baseline, from the gain that they had already achieved with the nebulized TYVASO. We also used the PAH SYMPACT questionnaire, which gave us an assessment of pulmonary arterial hypertension symptoms and the impacts on patients' life. For example, it asks questions like how fast can you walk on a flat surface? Do you have any capacity to carry heavy items? Can you do activities of daily life like personal hygiene or cooking? Are you feeling less frustrated or worried about pulmonary arterial hypertension? And we saw that the mean changes from baseline were improved across all domains scores at week 3 and week 11, with a significant improvement reported for physical impacts at week 3 and week 11, and cognitive and emotional impacts at week 3. Also, 98% of the patients in BREEZE reported satisfaction with TYVASO DPI after 3 weeks. This is important because high satisfaction scores have been associated with better compliance, which could be associated with clinical improvements.
Please summarize the key takeaways of BREEZE.
In BREEZE, we demonstrated that TYVASO DPI was safe, and tolerable for patients based on the safety profile and the pharmacokinetics, all of which were similar to those on nebulized TYVASO. We saw an improvement in the 6-minute walk distance from baseline and an improvement on patient-reported impact in addition to the high patient satisfaction score with TYVASO DPI.
For additional resources and instructional videos for TYVASO DPI, please visit www.tyvasohcp.com. Important safety information. Indication: TYVASO, treprostinil inhalation solution, and TYVASO DPI, treprostinil inhalation powder, are prostacyclin mimetics indicated for the treatment of pulmonary arterial hypertension, PAH-WHO Group 1, to improve exercise ability. Studies with TYVASO establishing effectiveness predominantly included patients with NYHA functional class 3 symptoms and etiologies of idiopathic or heritable PAH, 56%, or PAH associated with connective tissue diseases, 33%. The effects diminish over the minimum recommended dosing interval of 4 hours. Treatment timing can be adjusted for planned activities. While there are long-term data on use of treprostinil by other routes of administration, nearly all clinical experience with inhaled treprostinil has been on a background of an endothelin receptor antagonist, ERA, and/or a phosphodiesterase type 5 PDE5 inhibitor. The controlled clinical experience with TYVASO was limited to 12 weeks in duration. Pulmonary hypertension associated with interstitial lung disease, PH-ILD, WHO Group 3, to improve exercise ability. The study with TYVASO establishing effectiveness predominantly included patients with etiologies of idiopathic interstitial pneumonia, IIP 45%, inclusive of idiopathic pulmonary fibrosis, IPF, combined pulmonary fibrosis and emphysema, CPFE 25%, and WHO Group 3 connective tissue disease 22%. Important safety information, warnings, and precautions. TYVASO and TYVASO DPI are pulmonary and systemic vasodilators. In patients with low systemic arterial pressure, either product may produce symptomatic hypotension. Both products inhibit platelet aggregation and increase the risk of bleeding. Co-administration of a cytochrome P450 CYP2C8 enzyme inhibitor, for example gemfibrozil, may increase exposure, both Cmax and AUC, to treprostinil. Co-administration of a CYP2C8 enzyme inducer, for example rifampin, may decrease exposure to treprostinil. Increased exposure is likely to increase adverse events associated with treprostinil administration, whereas decreased exposure is likely to reduce clinical effectiveness. Like other inhaled prostaglandins, TYVASO and TYVASO DPI may cause acute bronchospasm. Patients with asthma or chronic obstructive pulmonary disease, COPD, or other bronchial hyperreactivity are at increased risk for bronchospasm. Ensure that such patients are treated optimally for reactive airway disease prior to and during treatment with TYVASO and TYVASO DPI. Drug interactions, specific populations. The concomitant use of either product with diuretics, antihypertensives, or other vasodilators may increase the risk of symptomatic hypotension. Human pharmacokinetic studies with an oral formulation of treprostinil, treprostinil diolamine, indicated that co-administration of the cytochrome P450, CYP2C8 enzyme inhibitor gemfibrozil, increases exposure, both Cmax and AUC, to treprostinil. Co-administration of the CYP2C8 enzyme inducer rifampin decreases exposure to treprostinil. It is unclear if the safety and efficacy of treprostinil by the inhalation route are altered by inhibitors or inducers of CYP2C8. Limited case reports of treprostinil use in pregnant women are insufficient to inform a drug-associated risk of adverse developmental outcomes. However, pulmonary arterial hypertension is associated with an increased risk of maternal and fetal mortality. There are no data on the presence of treprostinil in human milk, the effects on the breastfed infant, or the effects on milk production. Safety and effectiveness in pediatric patients have not been established. Across clinical studies used to establish the effectiveness of TYVASO in patients with PAH and PH-ILD, 268, 47.8%, patients aged 65 years and over were enrolled. The treatment effects and safety profile observed in geriatric patients were similar to younger patients. In general, dose selection for an elderly patient should be cautious. reflecting the greater frequency of hepatic, renal, or cardiac dysfunction, and of concomitant diseases or other drug therapy. Adverse reactions. Pulmonary arterial hypertension, WHO Group 1. In a 12-week placebo-controlled study, TRIUMPH-1, of 235 patients with PAH, WHO Group 1, and nearly all NYHA Functional Class 3, the most common adverse reactions seen with TYVASO in 4% and more of PAH patients, and more than 3% greater than placebo, were cough, 54% versus 29%, headache, 41% versus 23%, throat irritation, pharyngolaryngeal pain, 25% versus 14%, nausea, 19% versus 11%, flushing, 15% versus less than 1%, and syncope, 6% versus less than 1%. In addition, adverse reactions occurring in 4% and more of patients were dizziness and diarrhea. In a 3-week open-label, single-sequence safety and tolerability study, BREEZE, conducted in 51 patients on stable doses of TYVASO, who switched to a corresponding dose of TYVASO DPI, the most commonly reported adverse events seen with TYVASO DPI in 4% and more of PAH patients during the 3-week treatment phase included cough, 35.3%, headache, 15.7%, dyspnea, 7.8%, and nausea, 5.9%. Pulmonary hypertension associated with ILD, WHO Group 3. In a 16-week placebo-controlled study, INCREASE, of 326 patients with PH-ILD, WHO Group 3, adverse reactions with TYVASO were similar to the experience in studies of PAH. Please see full prescribing information for TYVASO or TYVASO DPI, instructions for use manuals for TD100 and TD300 TYVASO inhalation system and TYVASO DPI inhalation powder, and additional information at www.tyvasohcp.com or call 1-844-UNITHER, 1-844-864-8437. Please see full prescribing information at www.tyvasohcp.com. Thank you for watching.